All right, good afternoon, and thank you again. Welcome to our Learning and Action Network LAN webinar, using traditional or community health workers to support community clinical partnerships and patient engagement. My name is Rebecca Bally, and I will be helping to moderate today. So before we get started, just a couple of points about our technology. We do want to hear from you, and throughout the presentation, we will be checking in. So I'd like to quickly just review that. To reduce feedback noise, everyone is and will remain on a global mute throughout the presentation, but we do have time set aside at multiple points to address your questions. So even if you submitted questions when you registered, we welcome you to still submit additional questions via the question pane, which you can find on your control panel when you hover towards the bottom of your screen. You can type them there and I will read your question for our experts to answer. Please also free to use that question pane to send me any messages or questions if you're having technical issues, and I will do my best to assist you. Any questions that we aren't able to get to can be addressed later via email. We'll provide contact information. And one question we always get is whether the slides will be available, and yes, the recording and the slides will be available and posted to the Health Insight website in about a week or so, and we will send you an automated email when those are ready. Another quick housekeeping item, just a brief introduction to Health Insight, who is hosting this webinar. Health Insight is the Quality Innovation Network Quality Improvement Organization, or QIN-QIO, serving Nevada, New Mexico, Utah, and Oregon. So there are 14 QIN-QIOs that bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that increase patient safety, make communities healthier, better coordinate post-hospital care, and improve clinical quality. QIN-QIO work is grounded in principles aligning with the goals of the Centers for Medicare and Medicaid Services CMS quality strategy to eliminate disparities, strengthen infrastructure and data systems, and enable innovation and foster learning organizations. Along with the 13 other regional QIN-QIOs, Health Insight is leading healthcare quality improvement initiatives, including work aligning with the Million Hearts Initiative for the Medicare program for a 5-year period through 2019. So we work with providers across the spectrum to develop and apply strategies for delivering safer, more efficient care. And this webinar is part of the Learning and Action Network LAN efforts under that project. Without further ado, I would like to now introduce to you our expert presenters. We have on the phone with us today Tracy Carver, who has worked with Health Insight Oregon since 2011. Currently, she manages the Centers for Medicare and Medicaid Services, CMS, Everyone with Diabetes Counts initiative, and the Integrating Evidence-Based Self-Management Education into Patient Care Special Innovation Project in Oregon. Previously, Tracy served as a quality improvement specialist focused on medication safety initiatives. And prior to joining Health Insight, Tracy worked for the Oregon Health Authority, coordinating initiatives focused on community-based approaches to self-management, health literacy, disparities, and reducing the burden of chronic disease. She has more than 9 years of experience leading innovative quality improvement and population health initiatives. She holds a Master of Public Administration degree from Portland State University. We also have on the line with us today Julie Gregory, who has been a registered nurse for almost 40 years and has worked in most areas of the hospital with a strong background in intensive care and home health. One of her passions is community health and outreach. She has been at Good Shepherd as Director of Education Services for 17 years. Half of Julie's job involves staff, nursing, physician education, and competency, and the other half is centered around community health and outreach. Both areas, the hospital side and the community side, speak to her soul in different yet critical ways. She has helped build a number of programs for Good Shepherd, including the Connections program starting in November 2014 with funding from 2 different grants. On our webinar today, Julie will explain more about the Connections program as a model for working with community health workers to achieve better health outcomes for patients. We also have on the call today Bonnie Pickens, who has been at Kaiser Permanente since August 2015. She currently works as a supervisor for community health navigators embedded in Kaiser clinics in Multnomah County. She also works on a model to integrate community health workers as part of the primary care team. Her work is primarily focused on implementing social needs, screening tools, and building robust community referral pathways. She received her MPH in Health Management and Policy from Portland State in 2015. She also has a background in mental health case management and tobacco prevention for vulnerable populations. She is joined on the call by Gail Brownmiller, who has extensive knowledge and experience from over 25 years leading nonprofit organizations. Most recently, she served for 10 years as the Director of Community Programs at the Susan G. Komen, Oregon, and Southwest Washington. Gail is working with Familias en Acción to strengthen its foundations and grow the programs in order to better serve the Latino community. Prior to Komen, Gail served as Executive Director for 3 nonprofit agencies that developed affordable housing for a variety of special populations. They included adults with mental illness, people who were homeless, and low-income seniors. She is married with 2 grown daughters and loves living in the Northwest. So I know that was a lot, but we are so grateful to have such fantastic expert presenters to share their information today. So thank you so much for joining. And without further ado, I will turn things over to Tracy Carver.
All right, thank you, Becca. Apologize, there we go. So today we have put together a wonderful webinar for you with a couple of examples of some successful clinical community partnership models that use community health workers that are happening in Oregon. So here are the objectives of what we're hoping that you are able to take away from today's presentation. In addition to hearing about these great examples, we will want you to be listening for strategies in which how community health workers can help you to increase and improve care coordination for your patients, particularly between the clinical and community services that they may need. You'll also be hearing strategies around how community health workers can help increase patient engagement, as well as the skills that they need day to day to be successful in managing their chronic conditions and health needs. And then last, we'll briefly introduce some ideas for thinking about how you might build community health services, community health worker services into care delivery. So I wanted to make sure that everybody on the call had a common understanding of what a community health worker is. In Oregon, the term traditional health worker has been used as an umbrella term that includes community health workers, which is why we named the presentation that way. I know in some of the other states, traditional health worker is not a term that is used. So the definition on your screen is from the American Public Health Association. And in essence, community health workers are frontline trusted members of the community. They're often leaders within their communities. And they serve as a liaison between the health system, social services, and the community that they serve. And in particular, community health workers have been effective and have a long and rich history working with populations that we know from data experience poor health outcomes and may have a harder time accessing and engaging effectively in care. So I really liked this quote from the CDC that I wanted to share with you. It's out of a policy brief that you can see the link at the bottom of the slide. But the CDC has recognized community health workers as culturally competent mediators for members of diverse communities. And they have also recognized community health workers as effective in promoting the use of primary and follow-up care for preventing and managing chronic disease. So community health workers are, there's been lots of studies, and they are a demonstrated valuable member of the care team. All right, so without further ado, I'm going to introduce you to our first speaker. I know Becca already did a lovely introduction for her, for Julie Gregory. Oh, I don't know why this is forwarding on me, sorry. So I won't say much more except to say that Julie has been managing the Connections program since its inception in 2014, and she'll be sharing their great work with you today. So Julie, all yours.
Great, thank you. Good morning, everyone. The Connections program we started, recipient of 2 grants, which helped us kind of start the program. To date, we started seeing clients in like October, November of 2014. And so far, we've had over 3,000 referrals. We have full-time community health workers, 4 of whom are bilingual, Spanish-English bilingual, and 1 full-time nurse. So the program really exploded and obviously showed that there was a need in our community. The community, what is a community health worker? We had a great definition earlier, so I won't expand on it. I do want to talk more about the coordinating care and advocacy. Those are some of the primary roles that we feel we play when we're working with our clients from the community and trying to help them. So I won't go into that any further. Next slide, the roles of the community health worker. We talked a little bit about care coordination and advocacy. Patient navigation, one of the more complicated things that people deal with. When you're in the health field, it maybe doesn't seem as complicated, but it is to most people to try to get to the appointments, get the appointments made, get the services they need. All of that is much more complicated and complex than we would like to think it should be. It shouldn't be that way, but it is. And we work with clients, try to help them become more self-sufficient if this is a possibility for them. Obviously, if you have a client who has dementia or a severe mental or behavioral health component, sometimes self-sufficiency is not necessarily going to be the prime goal. But we do try there. We try to help them get to a point where they can make their own appointments, they can make their own transportation arrangements, and that they understand their health condition and how to be more self-sufficient with that. That's our primary goal. Next slide. Part of what we do is home visits. We do try to have always a face-to-face if we can. Now that face-to-face meeting may take place in the emergency department. Sometimes they're in the hospital and we go up to the floor and we actually go to their bedside to talk with them. It can be in a provider office. That happens actually fairly common. And we'll be called down there. We do have community health workers located in the clinics that the hospital that I work for owns. And but we'll go to any clinic and attend the appointment with them or start the referral process. When we do a home visit, we want to do a home safety assessment. And that can include all the things listed here: food security. We want to make sure that they have what they need. They won't always tell the provider, or if they're in a hospital or the emergency department, they won't always say, I don't have any food, or my home is not safe. They won't say those things sometimes, but when you get into the home, it's glaringly apparent that there are some issues. So we try to get be allowed to do a home assessment, and we go through the home and look at fall risk. That's another issue that we really look at. And medication reconciliation and management. Sometimes they won't share all the medications that they may be taking. We get into even the illegal aspects of drug use. So we talk about some of that, and they may not tell the provider some of those pieces of information that are key to know. And we will help them with the medication management and reconciliation. That's a big piece we find when there's a strong medical issue. They aren't taking their medication, and it could be something as simple as they can't afford it. They don't understand how to take it. That's another real common one. So we will help them with making sure they can get their medications, that they are able to understand, if they are able to be taught how to set up a med box or understand how they should be taking them. If that's, again, beyond what they are capable of, then we will set up the medication boxes. We'll check with them, and we will continue to do that, and if there's no one else to be trained to do that. The physical safety, we deal with a lot of situations where there is domestic violence or threat of domestic violence, and so we do talk about that. We try to get them into resources, and then obviously any referrals to social support needs that they have, we try to make sure that that is part of what we're putting together for them and helping them with. The education and promotion, we really want to be able to provide some screenings in their home to make sure that they are doing well on the medical side, increasing their health knowledge. Again, if they're able to be understand that, we work with that, and the self-sufficiency. Our community health workers also are out at community events. We want to introduce people to the Connections program, but also how a community health worker might be able to help them with needs. A lot of community health workers here in our area, and so they can come through Connections, or if they're already a client at patient at a clinic that has community health workers, we will refer them directly there. That let them know that you need, whatever that need is. So we try to always make sure that people understand what a community health worker can do and how they can help them. And then sometimes social support is what's needed. They're lonely. They don't have anybody to check on them, that type of thing. So we work with our community partners to try to make sure that people have what they need. The health coaching, I didn't specifically get into this, but we do try to help them come up with an overall comprehensive plan of care so that they can maintain the best health they can and the best plan for managing their lives. So the coaching is a big piece of it. Next slide, please. Some of the basic needs that we go in and assess are listed here. Housing. We deal with a lot of homeless people. And so home is where they are. And if that's the situation, we have done assessments in the cafe at Safeway, in the park. I mean, it's where we can talk with them, and then we try to get them into housing. And sometimes that works, and sometimes it doesn't. Some people living within four walls is not comfortable for them. So we have to be comfortable with where they are, and then try to set up the best plan we can, working with them in their situation. So transportation assistance, that's another big one that we work with, try to get them to appointments that they need to be at, and making sure that they have transportation. Food security, we talked about a little bit a couple minutes ago. That's a big one, whether we find out whether or not they really do have access to food. We will get them access. There are patients that we have right now that we've had long-term, because of their situations. We take food boxes to them once a month at least. And so we make sure that they have some of the basics that they need. One of the things that we assess for we work a lot with population health, so some of your chronic illnesses. And a diabetic, we may meet them in the provider office, and they're telling the doctor or the provider, I don't know why my A1C is going up. I'm doing everything you're telling me to do. I'm eating what you're telling me. I'm taking my medication. But we go into the home and we start looking in cupboards, and they have not one healthy food in the house. It's all processed foods, sweets, different things like that. So we can kind of, okay, let's go back and talk about that. Let's come up with a plan to maybe revisit that education. Maybe you had your diabetes education long enough ago that you need to refresh. So let's work on that. So we work on a lot of those components with the provider offices. The medical coverage and the financial piece, in 2014, if people can go back a couple of years, we were getting a lot of people signed up for Oregon Health Plan. Healthcare reform was really hitting, and we were trying to get people insured, and that was a lot of what we did. Now what we do is we are getting renewals done. We're finding that people are throwing away the renewal notices and that type of thing. So, okay, let's get back to that. Let's get that taken care of. If they don't have a primary care provider, we get them in with a primary care provider. Some of the safety issues we kind of talked about a little bit also. The next screen, please. The access to care, and like I said, coverage and renewals, that type of thing. If they have a chronic illness, and like I said, a lot of the ones that we work with do, we try to get them into some of the classes, excuse me, like we do a whole series of the Stanford University Living Well with chronic conditions, diabetes, and just today we're actually having the training on the chronic pain. We've not offered those classes yet, but we will. So we try to get them referred into those. If it's a diabetic, maybe they had their education a long time ago. Maybe they have never had official education on diabetes. So we get them into the diabetes program and get that educational piece. And we attend those appointments with them. We also can attend the classes with them if that is a need. We encourage them to bring someone else, but we can and do at times. Medication management we talked about. One of the things I'm going to mention here, and I'll tell you, the staff laugh at me when I say this, but at least 75% of our clients that we have in the Connections program have a mental or behavioral health component to their health care. And they laugh because they know it's higher than that. And I hesitate to say that it's 90% or something, but it probably is. That's probably a realistic number. And so it does complicate the plan you're trying to put together. And so we do work very closely with the mental and behavioral health services here in our Umatilla-Morrow County area. And but that does add some complexity to trying to put together a plan. Next screen, please. The health coaching we talked about a little bit, and a wellness plan. And we do try to negotiate with the patient and come up with a plan that they feel that they can accomplish and that we feel we can help them accomplish, and work together on that. And then we try to update the plans regularly. So as a goal is met, or maybe it's become unreachable for whatever reason, we adjust the plan. We can go out and do vital signs and weight, that type of thing, with the health screenings. We have been doing blood sugars. I'll tell you one particular client that we had showed up in the emergency department with a random blood sugar of almost 700. And they called me, and they were already down there meeting with her, the community health worker was, and they said, we're taking her down to the PCP office. And I said, well, stop by here and let's do an A1C. That way the PCP will have that additional piece of information. And sure enough, the A1C was 13.7. They were able to take that down with the patient. The provider had more information to be able to really work with that patient and get a better plan going. And we were able to be there during that appointment and back up what was said and the educational pieces that went with that. So it was really, to me, a nice wraparound of trying to get everybody working together with a common goal, which was to hopefully get that blood sugar under control and for long-term management. Next screen, please. We do have community health workers located in several of our clinics. And like I said, they do go to any of the other clinics and go on visits with the patients. Here, they're actually located. They have a desk. They're physically located there. So patients do get walked into them if the clinic staff identifies someone that they're concerned about. So that's worked really well. We also have identified some of the clinic patients with chronic illnesses or very complex health issues. Sometimes it's a new diagnosis, but it may feel overwhelming to that patient. So they'll call Connections and want a community health worker involved. And that has worked really, really well. We get them into the different classes, into the experts like the diabetes educators, that type of things. We also have people that respond to calls in the emergency department, and that's all day. We have coverage from 8:30 in the morning, typically until 10 o'clock at night, Monday through Friday, and on the weekends, it's till, excuse me, noon to 10, to try to hit the peak times that people might be in the emergency department. We don't have a lot of urgent care coverage in our area here that we would ideally like, but we still work with them and trying to provide education as to when they would be calling their primary care, should be calling their primary care provider. Maybe an urgent care might be a better option, and when the emergency department is the appropriate choice. So we do work with them on all of that. We follow up with them. We get referrals from everybody. We get self-referrals, and we get referrals from primary care provider offices, other community partners, the hospital case managers, clinic staff. We get referrals from all across the board. We have people that actually just walk in the door, and we'll go ahead and do an assessment. We follow up with them via telephone calls, sometimes letters, but we prefer face-to-face if at all possible. And we try to make sure that that happens. Next screen, please. If we also have regular meetings, with weekly meetings, multidisciplinary team meetings, where our community partners and the social service representatives, we all can connect together. And sometimes people connect via phone, sometimes they're here live, but they're weekly meetings where we can make sure that what we're doing is all wraparound care. We're all caring for that same patient. And are we all going the same direction? We want to make sure. And we will do separate MDTs for patients with a complex care. So that has worked really, really well. Next screen, please. As I mentioned, we have a lot of our clients have a mental or behavioral health component. So we do try to work with them and work with the different services that will help them with some of these concerns. Next screen, please. Our community health workers are state certified. They have had mental health first aid certification training. We have several instructors for the Stanford University programs, and we do refer patients there. And we refer them to like the Tai Chi for Better Balance. We have instructors here, and there's classes offered all over, so we get them in. Tobacco cessation, we have certified counselors here. Diabetes education. One of the pieces that we're rather kind of experimenting with right now is the Wellness Network. It's something we have here for our hospitalized patients, but also for community. So there's programs on health issues, and we can give them the code, and they can watch the different programs, and then we talk with them about what they learned. So that's how we provide some of the additional outreach that we do. The next step for the community, for connections, is we started a community paramedic program that's been recently. It's an adjunct to the Connections program, and a Connections community health worker goes out with the paramedic so that there's the medical piece as well as the all the other needs are addressed. The next step I want to do with Connections is I would love to have a social worker that is embedded in the program. We work with social services all over, and that's been great. I'd like to have one that can help us in the program. So that's our Connections program in a really fast and furious nutshell. The toolbox you see here, I will talk a little bit about the EDDI reports. Those are emergency department reports, and any hospital can get hooked up to those. And if a patient has been in the emergency department 5 or more times in a rolling calendar year, and for us, it can be anywhere, Oregon or Washington. I would have to check on the other states, but it generates an automatic report so we can follow up with those people. And sometimes we actually beat them to the emergency department, and we'll be there waiting for them so we can talk about what's really going on, because a lot of times it isn't necessarily a health issue. It's other pieces of their life that we need to try to help them with. So that's it for me.
Great. Thank you so much, Julie. I really appreciate you sharing all about your program and the fantastic work that Good Shepherd's doing. I know it's hard to do justice to such a enormous project in a short amount of time. So we have time for maybe 1 or 2 quick questions now, and remember, you can chat those in. Hopefully we'll have some time at the end, but if we don't, I know Julie was very gracious enough to provide her email, so if there are additional specific questions that folks have afterwards, they can follow up over email. And one question that came in, Julie, was just sort of about the startup. So you had mentioned early on in your presentation that there were 2 grants that you received to start this Connections program. So I imagine there was some conversation before about wanting to do this and having to apply for the grant. But what were, maybe if you could summarize the first 3 steps of, receiving the grant and sort of what's next for others who are thinking about starting a similar program.
Well, we talked about what's needed in our community, what isn't being met or met as thoroughly as we all would like to see, because we all deal with people where we are concerned that they're falling in the cracks, that type of thing. So that was the first conversation. We knew these 2 grants were available, coming up, and that was the initial start of the conversation. And we looked at community health workers, and back in early 2014, which is when we were writing these grants, I frankly had never heard of a community health worker. I'll just be really honest with you. And I had to research a lot. Okay, what do these people do? Who are we hiring? That type of thing. And when I read what they could do and the thoroughness of which they can get involved with their patients, I loved it. I loved the idea of being able to meet them where they are and really be able to put plans together. So after we did the research, then we wrote the grants. And one of them was a Medicare Flex grant. And we wanted to work with seniors and try to help them maintain in their home, but also making sure they had all the services they needed, the educational pieces that they needed. The other grant was through our coordinated care organization here in Eastern Oregon. And they had a grant opportunity and we wrote for it. We partnered, there were several others that wrote grants, and we partnered together after we were told we each got a grant, and brought to our own pieces to it. And it was mental health services, behavioral health services, so it was Lifeways and Umatilla County alcohol and drug treatment, and then Good Shepherd. And we created the Connections program. Their grant funding ran out after, of course, the year. And so we've kind of formed partnerships, but they're not as formalized. Good Shepherd has funded the Connections program since the grant funding ran out, because they see such a huge savings and benefit to the patients. It's just huge. One of the things that we did in the grant to track was we took off the EDDI report. If you remember, those are high utilizers. We talked about, okay, let's select the top 50 that are frequently using the emergency department, and we're going to track them for the length of the grant. Out of the top 50, we were able to connect with 33 of them. The other 17 either declined, had died, we couldn't reach them, whatever. Of the 33, we tracked them for 7 months. We had an 8% decrease in ED utilization in 7 months.
Wow.
Our goal was 10 months, or 10% in 12 months, and we were thrilled. And we also broke that down even a little further. We took the top 8 of those 33 and did, obviously, a broad figure. An ED visit is anywhere from $900 to $1,500. I don't know. I haven't done ED often enough. I think that seems kind of low, but okay, that's just me. But we took, because in an EDDI, you can look back at their prior utilization. You can look at the same time frame the year before. You can look at the prior quarter. You can select your time frame. So we were able to look at how many times they had been using the ED compared to how much they were now. And we used actually the $900 and said, okay, yes, we're guesstimating that had they used the ED like they had been, those 8 patients saved over $115,000.
Wow. So clearly, a very effective and useful program. And thank you again for sharing. And I apologize, we're on this, tight time frame, but we could probably spend the whole rest of the day just talking about all the great work that you're doing. And I'm hopeful that people will continue to ask questions through the chat. We had a couple more come in that we'll try and pause till the end of the webinar. and then continue over email some further conversation. But lots of great lessons learned. Thank you so much, Julie, for sharing about the Connections program. It's really fantastic work and a great model for folks on joining us today.
Thank you very much.
So I'll turn things over to Tracy to introduce our next presenters, and please keep answering or sending your questions through the chat. We'll try and see if we can get some conversation going there with answering the questions that have come in.
All right, thank you, Becca, and thank you, Julie. So our next presenters are Gail Brownmiller and Bonnie Pickens, as Becca introduced them at the beginning. Gail is Executive Director for Familias and Acción, and Bonnie works as the supervisor for the Community Health Navigator program at Kaiser, those navigators that are embedded in the clinics within the Portland area. And they have been working together on a pilot program that they're going to be sharing a little bit more information with you about today. So I'm going to hand it over now to Gail and Bonnie, and feel free to let me know when you want your slides forwarded.
Great, thank you.
Good afternoon. Thank you so much for having us. And you can go to the next slide. Just a quick overview of who Familias is. We're a very small nonprofit that focuses on serving Latino families. And we do three primary things. We have health navigators that work primarily on chronic disease and cancer as community health workers. We have education classes and a support group in Spanish for those people. And then we also do training for health professionals. And we do travel to Idaho, Utah, Washington, and Oregon doing palliative care training thanks to a grant from Cambia. So next slide. Let me just say for a moment what we're going to try and cover. I'm so glad Julie presented on her model, because she really described what a community health worker does who is working directly with the hospital. What we're going to talk about is community health workers that are still employed by a community-based agency but accept referrals from health systems. And the whole point of our project has been to figure out how do you track the work and how do you pay for it. So we were chosen, one of the reasons Familias was chosen is because we had worked with Pathways to Health, and we were already able to document that we were able to save 62% in ER, inpatient, and outpatient costs by working with the community health workers. So we had experience doing this, and then we went to work with Kaiser. So next slide, Bonnie.
All right, so and I'm just reading that people are having a little bit of difficulty hearing us. We're pulling this as close as possible so we can be heard. I'll turn up the volume a little bit. There we go. Okay. So his model basically, oh, can we go to the next slide? I'm sorry. Thank you. Familias and Kaiser received a 2-year grant to build a replicable model. And what this means is that we were basically charged to Kaiser connected with Familias early on, as a known, respected community agency that did valuable outreach to our Latino population. And they had obviously such great results in reducing ED utilization, and really at the core of it had the community's trust. And I would say the underlying foundation of our partnership is that the partnership is founded in the belief that the community health worker needs to stay connected to that community-based organization, because they come from the community, they have the already the valuable connections, and most importantly the trust, which we really can't even put a price tag to what how that propels this work. And I do want to put in a plug for, we just completed as a deliverable for our grant, a guide, an implementation guide on how to replicate this model. So everything that we chat about today will be in written form in that guide. So you can connect with us to find out more. All right, next slide, please. So in the beginning, we brought together, we had to learn a lot about each other's culture and values. Kaiser is a huge integrated health plan and health system. Familias is a relatively small community-based organization. We had to get together to really learn about each other's work and develop a charter which really lays out what our vision is for this work, what's in scope, what's out of scope for the community health workers, and also for the purpose of just the grant project. What our deliverables would be, build an evaluation from the beginning. I saw there was a question about metrics. How are we measuring the impact of the community health workers? And so we built that in from the beginning, as well as a timeline to keep ourselves accountable, and build some ground rules. I'll also say that we did a lot of this over big plates of food, and really wanted to develop trust among the organizations too. That's very critical. Next slide, please.
Community health workers, we chose something called Pathways to Health model. And I'm hoping that most of you have heard of it. It was created by Paul and Sarah Redding out of Ohio. And it is a way of documenting on the computer, online, how the work is being done with the community health worker. So what we did is we were able to create these pathways, and then we began to get standardized pathways, because it's one thing to create the work, and a pathway is whatever need the client has. So if they need transportation, that's one pathway. If they need housing assistance, that's one pathway. If they need help getting to a medical appointment, that's a pathway. And it's a way of documenting the work that community health workers instinctively do when they assist people. We also found that there are community health workers that get extra training and delivered what we kind of called was a direct service. So an example of that would be insurance. If somebody is trained through the state of Oregon to fill out the OHP insurance forms, we considered that a direct service because they were sitting down and actually filling out forms. It was a referral if they were going to send it to someone else to help them. So that's a little bit of difference there. Next slide, please. So knowing that we wanted to replicate this and be able to serve multiple groups, because in large areas you may have 20 different groups, African American, Native American, Asian, Latinos, other special needs populations. And the health system can't afford to hire a separate community health worker for each group that they want to serve, and yet they want somebody connected to that community. So by using what we call the Hub model, and this is also from Dr. Redding's, the Hub acts as a center. So the health system can send referrals for all kinds of people that need help. And then the Hub contracts with the various community agencies to provide that specific community health worker. So when they work with us, we only serve Latino patients, no one else. They might hire another agency to work with African American or Native American or other groups. So you have to have a mechanism for, again, tracking all this work and paying for it. And so what the Pathway to Health does is it attaches a value, a price to each pathway and each step in the pathway, so that, for instance, in a particular month, if you work on 3 pathways, then you would be paid for those 3 pathways in that month. And therefore, the health system can purchase the services that they need for that specific client. So we're going to move on to the next slide so you can see what a pathway looks like. We've got an example of a medical appointment. So all the pathways have the same process. They have an initiation point. So in this case, it says, do you have any health conditions that are not being treated? And if the person says yes, then you need to get them, probably say in this case, a primary care physician. Then you would go to the step. One would be a referral to a health provider, actually setting up that appointment. Next slide. And then the second step would be actually confirming, either going with that patient if you need them help, or making sure that they were able to do that. Then there's always a completion point. So again, you go back and make sure that they've completed everything. Next slide.
All right. This is one of the community health workers leading a cooking class at the Familia's office. We can go ahead and advance to the next slide. So you might be wondering, how did the potential patients get referred to the community health worker in the health system? And what we did, we have to do a lot of system-wide education with providers and informing them what community health workers do. A lot of that was in Julie's presentation, what the specific areas that community health workers can impact. And then what we did was build a pool for those of you who use the electronic health record system. We built a pool that was specific to referrals for the community health worker program. So once a member is identified from a provider, a social worker, someone in membership services, a diabetes case manager, anywhere across the system, they're able to send a referral to this provider, to this community health worker pool to initiate some type of action. And they just let us know what the concerns are, what they'd like the community health worker to do. And then someone who has been myself and also a colleague of mine reviews these referrals to just make sure that they are something a community health worker could make an impact with. And that's something that we, a bucket of work that we had outlined in our charter of what a community health worker would be tasked with. And also not sending along referrals that are just basic translation services, something like, can a community health worker give a ride to a patient? Those things are not within the scope of a community health worker. So you have to have someone, a referral processor in charge of vetting that. And then after it's been vetted, the referral is sent over to the community organization. And in this case, we use Project Access Now as the hub, where we send a referral over to Project Access Now, who would then refer to the community organization that would have the community health worker work with that particular patient. All right, so next slide, please. So one thing that we wanted to really keep in mind when going through these referrals, and also knowing the kind of patients that a community health worker would engage, we wanted to make sure that we were not overwhelming the community health worker, that there were specific guidelines for what type of panel that our community health workers could carry. also set up some kind of structure in terms of what high priority patients are, what medium priority patients are, and what low priority low priority tasks are. And it's not that, you know, one patient is like more, you know, valuable than the other. We'd like to serve all our patients, but we have to be realistic and also know that, you know, a case mix is important, and also having appropriate panel sizes is important. And so these are the various things within those 3 categories that we identified as, you know, being very specific action for the community health worker, and what we would, say if we had a referral come in for someone who needed a transplant and needed help, you know, walking through that process, raising funds, you know, and getting connected with culturally sensitive care, getting connected with counseling, we would prioritize that patient. All right, next slide, please.
Okay, so the next one is just a sample of the payments, so you can see. I could spend a lot of time explaining it, but basically every time the community health worker sits down and does our assessment, which does take an hour and a half to 2 hours, they get paid $500. And then for each of the ones you see listed there, that is the price they get paid. And our goal is for a community health worker to generate income of around $125,000 per year. Now notice I use the terms generate income. This is not just the cost of a community health worker. It's the community health worker plus all of the resources that they connect to, the chronic disease classes, the support group, the overhead that's involved, because we're trying to move our agency off grants and to 100% of these contracts with the community health workers. So the contract has to include all of the costs of being able to offer the services of a community health worker. Next slide. Here's just some ideas for payment models. This is kind of a fee for service. Some of you have talked about flexible spending. And the other thing that the Hub is working on are pooled funds from third-party payers. So that might include county health departments, it might include the criminal justice, domestic violence, all those other services that community health workers connect their clients to. Next slide.
All right. This is an IT class. All right, so this is what the evaluation, the current evaluation that we're doing right now. We're testing 3 different models. One is Kaiser Navigation Services, which we have our own navigators embedded in each of our primary care clinics. They are bound by clinic walls, though, so they don't do community health, or they don't do community visits. And they also don't necessarily do long-term support. They take more of a population health approach. And then we have a fully integrated community health worker currently. One of Gail's community health workers, what has been embedded in one of the clinic sites to just see how it would work to have a community health worker on site, knowing that again, wouldn't probably be a long-term solution for outreaching to very many diverse communities, because we wouldn't be able to employ or contract with a lot of individual community agencies. But we're wanting to test each of these models to see what their strengths are and what the biggest impact would be for various populations. And then we have the Hub community health model, which is the kind of wave of the future, what we are testing now. So you can move to the next slide. And some of the metrics that we are evaluating are number of pathways completed. So Gail gave you an overview of what those pathways are. A score on patient activation measure, so the PAM, how compelled the patient is to moving towards stage, but the stages of change. So how motivated and active a patient is in their treatment plan that they're working on with the community provider. And then a change in care gaps. So care gaps include things like pap smears, breast exams, colon screenings. So how many of those we see the community health worker quote unquote closing? Reduction in emergency room admissions, of course, A1C levels, and then the no-show rate. The idea is that once we connect people to transportation resources or healthcare, just get them really engaged in their care, that the no-show rate will go down. All right, last slide.
Okay, and the key, I would say, to this whole process is the referral. If you're working with the hub and you're sending referrals to multiple agencies, having a good referral process is the key. And the second is what I put at the end, be careful what you evaluate. You get what you ask for. And so you have to really design the evaluation at the beginning, because that will drive the kinds of referrals that you need to make to be successful. So thank you very much, and do check out our guide. It's on our website at familiasandaccion.org. Thank you.
Perfect. Thank you so much, Bonnie and Gail. I wonder if you could put that link in the chat for folks to have access to. And we have time for maybe just one question before we wrap things up with Tracy. And one of the questions that came in, I think some of the other ones you started answering about outcome measures and resources, but how are things going with embedded CHWs versus the hub-based CHWs?
Yeah, so the embedded CHW was the first community health worker that we worked with in this grant. And he sits at one of our clinics, the Rockwood Clinic in Portland, about 2 days a week, and the rest is obviously spent in the community. And that we've had pretty good success in terms of providers just pulling that community health worker out to meet with patients in the moment. I think that people know a lot more about what he does, so to speak, just because he has a presence in the clinic. And then the hub-based community health worker, one thing that we're testing out is actually a drop-in site for community partners to, so this, the hub community health worker comes by, occasionally, once a week or so, but he has to be let in by, a staff member and doesn't have necessarily the access that the embedded community health worker has. So we've seen more referrals with the embedded community health worker, but I think the hub community health worker is so new. And the idea is that once we have a lot of health system knowledge and what these services are, and also my team, the community health navigators, are kind of the gatekeeper to community resources, that we'll see a lot more referrals drive up for reaching out to diverse, vulnerable populations.
Great. Were you going to add something, Gail? Sorry.
No, I'm fine.
Great, thank you. And I know that we probably need another hour just for questions. It's such a good topic. So we'll definitely connect you if your question wasn't answered following the webinar to help get those answers for you. Real quick, because I know we're running low on time, I did want to just make the link for folks to a couple of ways in which you can start to think about how you might financially support having a community health worker service, either through an embedded model where you actually have a community health worker on staff, or through some sort of a partnership, as you heard from Gail and Bonnie. So right now, Medicare does not have a direct fee-for-service way to bill for community health worker services, but there are a couple of places that you can start to look and do an analysis on the return on investment for your organization. So if you're doing under the Medicare Quality and Payment Program, if you are doing the MIPS track, here are a few of the improvement activities that community health worker services can be used to support. And I don't have time to go into details on quality payment program and MIPS, but if you have no idea what I'm talking about, please contact me and we'll certainly provide you with more information. So I've provided the codes here. On the next slide, you'll see a link to where you can actually explore these improvement activities along with their definitions. There's also 2 fee-for-service codes that there are demonstrated models being tested right now in different parts of the country where community health workers or patient navigators are being used to support patient education and are embedded into a comprehensive program that then can be billed for Medicare. Those are listed at the bottom, the DSMT, which is diabetes self-management, and the health behavior assessment and intervention codes. Again, if you'd like more information, please reach out to me. Here's the links. The first one is just the CMS link to their quality payment program site. The second one is a product that we developed to help you distill some simple steps for getting started with MIPS and reporting. Look at number 8 in particular because it provides you with information about documenting what you're going to need if you're audited for attesting to those improvement activities using a community health worker. And then similarly, some resources for those fee-for-service codes that I just shared. And I don't have time, but if you have questions about this, but please reach out and I'm happy to talk to you more particular about this diabetes educator practice levels. For Medicaid, I just shared a couple examples here for you to explore after the call. The Pathways Contracting Pilot Implementation Guide is actually the guide that Bonnie referenced. That's their guide. So the link is right there for you on the second bullet. The first bullet is a policy that the Eastern Oregon Coordinated Care Organization has put out and is doing quite a bit of work around helping clinics operationalize payment for reimbursement rather for community health workers. And this third bullet is a great webinar that was done last year through the Quality Corporation PCPCI series that has a number of resources in it around looking at integrating community health worker services into care. If you have questions about how you even get started or find a community health worker in your state, the links are on this slide. And you can also reach out to your point of contact at Health Insight if you need further assistance with making this bridge, and then a few other resources for you. So when these slides come out, if you're interested, please explore these different resources. I think that we are about out of time, so I'm going to pass it back to Becca.
Perfect. Thank you, Tracy. And I hate to be the person who's always crunching us for time, but we had a suggestion, and I think it's a good one, to include some questions and answers in the email with the link to the recording and slides. So we will try and do that. I'll work with our speakers. Thank you for submitting your questions. If you continue to have them, feel free to email. On the next slide, I think we have contact information for everyone as well. And other than that, we ask you to please take a couple minutes to evaluate the webinar, let us know how we're doing and how we can continue to improve. Probably we'll hear that we could have used another 30 minutes, and that's fine too. And then our next webinar in this series will be Wednesday, August 16th, and it'll be at the same time over that lunch hour, and it'll be on blood pressure protocols. So I will put the link to the survey in the chat, and also we'll include it in the follow-up email, the automated email that you'll get from Zoom. But without further over time, so thank you so much to everyone who joined us this afternoon, and thank you to our fantastic presenters about taking the time to really put all this work together and continuing to champion this amazing work. So thank you, Julie and Bonnie and Gail and Tracy, and thank you to everyone who joined us. Have a great rest of your afternoon.